Hi, I'm Dr. David Lee, and I'm the director of the Cardiac Catheterization Lab at Stanford University. It's my great pleasure today to introduce my friend and colleague, Dr. Bill Fearon, who's the director of Interventional Cardiology at Stanford. And today we're going to talk about aortic valve disease, and specifically aortic stenosis.
Thanks, David.
Bill, tell us a little bit more about aortic stenosis and why is it important?
Yeah, so aortic stenosis refers to narrowing of one of the valves in the heart, the aortic valve. It's one of the four valves, and it's the valve that is supposed to open when the heart pumps and allow blood to leave the left ventricle and go out the aorta to the rest of the body. And then the leaflets close and prevent blood from leaking back into the heart. Aortic stenosis refers to when those leaflets, instead of opening and closing widely, they are thickened and narrowed and don't open well. And that leads to increased pressure in the heart, and it can lead to buildup of pressure in the lungs and make people feel short of breath. Sometimes they can have chest pain. Sometimes not enough blood gets to their head and they get lightheaded and dizzy. And aortic stenosis is a significant problem. 5% or more of patients over 75 have significant aortic stenosis. And so it's something that we deal with on a very common basis.
Now, things have changed in terms of how we treat this over the years. Tell me a little bit more about the options now for treating aortic stenosis.
Right. So aortic stenosis is one of those problems that there's not really any good medical therapy. It's a mechanical problem, and you have to fix it by removing the valve or replacing the valve. And traditionally, that had meant doing open heart surgery to remove the old valve and sew in a new one. And that means, being hospitalized usually for 5 to 7 days, and sometimes takes, 2 to 3 months to recover completely from that. And there are inherent risks, as you can imagine. So about 12 years ago at Stanford, we started doing what's called transcatheter aortic valve replacement. And that refers to replacing the valve by using a catheter through the groin, the femoral artery in the groin. And basically, what it means is that patient doesn't have to have sternotomy or have to have their breastbone cracked, and they don't have to have general anesthesia, and their hospitalization is much shorter.
So you don't have to go to the operating room for aortic stenosis?
No, we typically do it in the catheterization laboratory in conjunction with our cardiac surgeons. It's a team effort, and also with anesthesiologists. What happens is the patient is awake but very sleepy, so they're comfortable, and we insert a tube or catheter in the femoral artery in the groin, and through that we're able to run the new valve. And the valve, it's like a cylinder of chicken wire or a stent, and basically we advance that up the aorta and across the narrowed valve. And once we're happy with the positioning, then we deploy it. And basically that's usually by inflating a balloon or retracting a sheath for the self-expanding ones. And the new valve it's like a stent, as I said. It pushes up the old leaflets and creates room for blood to leave the heart. And sewn on the inside of that stent are new leaflets that come from part of a cow's heart or pig's heart, and they start opening and closing right away. We never have to stop the patient's heart during the procedure. And once we're happy with the position and function of the valve, then we remove our equipment and put a little suture in the groin, and the procedure's over.
What would the patient expect, in terms of their state? And we know traditional surgery, their chest is open, they have to be closed up afterwards. Oftentimes they're in the hospital for a week or potentially longer. How does TAVR fit in that scheme?
So typically, the patient comes into the hospital in the morning, and we do the procedure. It takes about an hour, from setup time to the patient leaving the room. The actual time we're working is even shorter than that. Like I said, the patient's awake during the procedure but sleepy. So then they go to the recovery room, and they usually spend a little while, maybe an hour there, recovering, monitoring the heart rate and blood pressure. And then they'll go to the regular hospital ward, and they'll spend the night in the hospital. And then typically, as long as they're feeling okay and comfortable with the plan, they'll go home the next day.
Wow. So overnight.
Yep, and
Wow,
then
that's great.
they, because they've had catheters in the arteries in the leg, we ask them to take it easy for about a week, meaning they can do regular walking and going up and down stairs and things like that, but we don't want them lifting anything heavy or riding a bike or doing something that might put strain onto the artery.
So what patients with aortic stenosis are actually eligible for TAVR? Is it everybody?
Yeah, so it's really interesting. Initially when we first started doing this, the paradigm was that everyone was a surgical candidate, and only if they weren't a surgical candidate, then you would consider TAVR. And because of some of the data that has been generated over the past decade, we now have switched things, and everyone is considered a TAVR candidate. And then if there's some reason why TAVR is not feasible, or we think you wouldn't have as good a result as we'd like in it, then we consider surgery.
Do patients ask you when they're considering TAVR versus open heart surgery and the valve replacement, how long do the valves last compared to a surgical valve, for instance?
Yeah, so that is a great question, and it's still a little bit of an unknown. Part of the reason is, although at Stanford we've been doing it for 12 years, initially most of the patients were very elderly, and they would end up passing away from some other cause without knowing, their valve was still functioning fine. So we don't really have long-term data. The other issue is that the valves have changed, and so the newest generation of valves that we're using have been around for 3 or 4 years. Now, we do have some studies of comparisons where patients were randomly assigned, half got traditional surgery and half got a TAVR valve, and out to 5 years, both valves seem to be functioning equally well. And we know that the surgical valves in general last 10 to 15 years. And so we're hopeful that it's the same for the TAVR valves, but that's something that we need to continue to gain more data and information on.
And what if the patient doesn't have a lot of symptoms? That is, and this is not that uncommon, as you know. A patient may have severe aortic stenosis, but very little in terms of symptoms. Are they also eligible, or do we still wait until people have symptoms till we treat them?
Yeah, it's a great question. And we traditionally, we would always wait because treatment meant having open heart surgery, and you kind of wanted to put that off until you absolutely had to go forward with it. But there are data now to suggest that even in asymptomatic patients, and I should mention that many people can have severe aortic stenosis and live for years without developing symptoms. But there are data now that suggests that the heart may not like that, as you can imagine, and that there may be changes in the heart muscle and function that are bad, and that treating the valve sooner would be better even if the patient's not having symptoms. And so we're part of an investigation or trial looking at this called early TAVR, and it's including patients with severe aortic stenosis without symptoms. And they get randomized to either an upfront TAVR procedure or to the standard of care, which is, again, close monitoring. And then when they develop symptoms, we do TAVR.
Are there any new devices that are coming into play, or to make the procedure even safer than what it is now?
Yes, so there are some devices that are already available and others that are being tested. For example, something called cerebral protection. It's a device where we advance a catheter through the arm, and it allows us to block any debris from going up and potentially causing a stroke. And there are new valves that are being developed as well. And particularly, for one issue that we pretty commonly face, especially in younger patients, something called bicuspid aortic stenosis. And so these patients were born with a malformed valve, and they haven't been as well studied with TAVR. And there are some differences in their valve morphology that might be amenable to, or might be better suited for a new technology.
Great. Thanks so much, Bill.
Thank you.